Our next speaker is Jenny Perold of South Africa. She has over 30 years experience in cochlear implantation and is the coordinator of the Tygerberg Hospital Stellenbosch University Cochlear Implant Unit. The floor is yours, Jenny.
Thank you, Ruth. And it sounds like India and South Africa have a lot of parallels. So thank you for inviting me. South Africa is as you can advance the slide. South Africa is a deeply unequal society with severe levels of poverty and unemployment. 34.4% of the total population and 44% of young people are unemployed. Where does this leave our deaf population? A quarter of the population live below the food poverty line. In terms of children, 21.3% of children under the age of 15 do not live with their parents, and 62% of children are considered multidimensionally poor. In terms of children and hearing loss, the 2011 census.
Jenny, just
yes.
Is your camera off, please?
Yes, sorry.
Okay, we'd love to see you.
Okay.
Nice to see you.
Sorry about that.
Thank you.
The average age of identification of hearing loss is between 22 and 44.5 months, which is obviously very late. And in the Western Cape, a recent study done of children at Red Cross Hospital that were identified with hearing loss, over half of them had a profound hearing loss. South Africa has a two-tiered, highly unequal healthcare system. Sounds a bit like India too. The public sector is state-funded and caters to the majority, 71% of the population. The private sector is largely funded through individual contributions to medical aid schemes or health insurance and serves around 27% of the population. Tuberculosis is the leading cause of death, and HIV is the 7th leading cause of death. We have the biggest HIV pandemic in the world, and 70% of people with HIV are on ARVs. So given the high expense of cochlear implant devices, within a low middle income country such as South Africa with its limited resources, high disease burden and funding constraints, it is understandable that the various healthcare priorities must be weighed against one another. So this background has necessitated an expansion of the usual considerations for selection of patients for cochlear implantation, and particularly this applies in the state sector. This aims to ensure the cost-effective cochlear implantation to optimize outcomes and use and minimize ineffective expenditure due to non-use or poor outcomes. Over and above the standard selection considerations, the candidate or their family should demonstrate financial ability and the infrastructure to support the long-term maintenance of their device and the rehabilitation process. So we use social workers extensively in the state sector, particularly to evaluate their ability to maintain the device in the long term. So this obviously means that a patient who has no income or poor limited infrastructure with which to maintain the device after implantation cannot be considered a candidate. And this is a real catch-22 situation, as this then perpetuates their unemployability and their already extremely limited employment options. The cochlear implantation was established in South Africa in 1986, and since then about 3,300 surgeries have been performed with a total of about 2,700 recipients. And just to put this into context, the UK has a similar population to South Africa, a little bit more, and has implanted almost 20,000 patients. We have since 1986, 12 programs have developed in South Africa. Audiologists do additional training in cochlear implants, and we have a good support system of listening and spoken language therapists and 3 fully qualified AV therapists. Our South African Cochlear Implant Group was established in 1998, and we have our quality standards and protocols have been developed based on international guidelines. So a significant challenge for us is the uneven geographic distribution and unequal accessibility of cochlear implant programs in terms of state versus public healthcare versus private healthcare. So in the private sector, there are varied levels of cover according to the patient's specific healthcare plan. Some of the healthcare insurance doesn't cover cochlear implants, and some are very supportive. In the state sector, there are varied levels of long-term support in 12 programs. We have a few charity organizations and foundations, but they primarily assist patients with their own fundraising efforts. They're not dedicated to raise money for patients. Okay. A recent audit that has been done shows the disparity between access to cochlear implantation between the private and the state sector, with the provision of state implants being under 1/5 of our total population. Okay. This graph demonstrates the change in funding of CI over the last 24 years in our cochlear implant program at Tygerberg Hospital. But it shows an encouraging increase over time in funding from both the private and the state sectors. A recent audit, also in our program by Müller, showed that of the 215 patients implanted through the state in our program, 16 no longer rely on state funding because they now belong to medical aids, but almost 70% rely on the state for either upgrades only or for upgrades and repairs. Due to the paucity of CI programs in the rest of Africa, many patients have been implanted in South Africa and are looked after by the 3 bigger cochlear implant programs. So a total of 74 patients outside of South Africa are managed within our borders, but there are significant challenges associated with this. Primarily that everything needs to be self-funded by these patients, and visa applications and processes are very laborious and are generally supported by the cochlear implant audiologists. This is not a comprehensive list of all the challenges, and managing distant patients from other countries comes with its own unique set of challenges. Tele-intervention has been very successful and is in place for especially the children with the speech and language therapists. So our biggest challenges for funding is keeping patients on the air, particularly our state patients. And then patients very often have to pay out of their own pockets for mapping, for parts, for repairs, and for rehabilitation. And in the state, particularly in the state sector, we face a sometimes impossible, tough job of appropriate patient selection. Our team tries extensively to assist potential and existing patients in finding employment or internships, learnerships. So what have we done to try to increase funding and awareness? We have included funders in our national meetings and conferences. So for example, our conference in 2019, we had a whole afternoon session where private and state funders were invited to present on their funding models, and we had a specific session on funding and cost effectiveness. The value was really cochlear implant teams gained good insights into the challenges faced by funders in prioritizing healthcare, hearing healthcare. And the funders also understood more about cost effectiveness and that cochlear implantation is a good spend. And we did see after this a slightly increased allocation of funds. Our team also has an annual newsletter of patient stories that we send out to the funders in the state and private sectors. We try to have regular meetings and communication with funders, and that is our SACIG group. NPOs have been established by some of the programs, and fundraising efforts and activities are supported by the programs. but we rely a lot on donations of parts from patients who upgrade and encourage them to pay it forward. So if you'll play the video, Kez. There's no sound.
Oh, sorry, the sound worked before. Yes.
My name is Valencia Zele. I am 9 years old. I am in grade 3 at Carol Detroit. I had my cochlear when I was 2 years old. I love my cochlear so much. It helps me to hear and learn. Without my cochlear, I can't hear. I'm so grateful that I have a cochlear. Thank you very much. My name is...
Thank you.
Thank you very much,
Thank you.
Jenny, and very inspirational closing comment. Brian, I don't see any questions in the chat room. Are there any?
No, I can't see any in the chat room. Just very quickly, Jenny, could you say what do you think would make the most difference in being able to increase access to cochlear implants more within your context? That was a fascinating explanation, but what would make the most difference to you?
I think the most powerful story to tell is patients telling their stories. And if we are identifying good advocates from the people who've had received cochlear implant is the most powerful story. And then obviously backing it up with the type of research that you and Sue are publishing in the Kika literature and website. But
That's great, thank you.
It's an ongoing, one's got to keep at it, as Neelam was saying, it's an ongoing thing.
Absolutely. No, thank you.